Hello and welcome. Dr. Anthony Gonzalez here again with Miami Community Health. We're here with another health important topic to talk with you today about another topic. Our last show, we talked a lot about men's health. We talked about testosterone, the benefits of testosterone and whether it'd be good, and some of the Mayo studies, the Mayo Clinic studies showing the benefits of testosterone in men. Today, we're going to change a little bit and we're going to talk about women. And what better than to bring an OBGYN, a good friend of mine, a great gynecologist, obstetrician here in our community, Dr. Jason James. Jason, welcome.
Thank you.
All righty. So, we know he's an OBGYN, obstetrics and gynecology. Well, tell us a little bit about yourself.
Sure. Well, thanks for having me. I guess I wear two hats, really. My main hat is being an OBGYN, which, as you said, is an obstetrician gynecologist, means basically primary care for women. Gynecology is primary care for women, taking care of women from adolescence all the way through end of life. And obstetrics is delivering babies. So that's my main hat. Kind of split my time through delivering babies, being in the hospital, being in the office. And then my other hat is recently elected as president of the medical staff at Baptist Hospital. So that's more of an administrative role, kind of representing the medical staff to the administration and vice versa at Baptist Hospital, which, one of the premier institutions for healthcare in South Florida.
Yeah. We're going to talk about that other job. We're going to focus first on OB and GYN on the obstetrics and gynecology. And then we're going to talk about that role of president of medical staff. And I think it's important for our viewers to understand that, you may have a CEO of a hospital, but the medical staff and the doctors need to have representation. And that's what Dr. James does for us. So let's talk about gynecological cancer. Everybody's always worried about cancer. How can a woman make sure that they don't have cancer? How do they get checked out?
Sure. So, as I was saying, being an OBGYN means primary care for women. And one of the primary things we're doing is trying to do primary prevention or secondary detection of cancers early. So, when you talk about female cancers, you think about breast cancer, obviously, is a big one. And then in the gynecological area, you have vaginal cancer, cervical cancer, vulvar cancer, which many people haven't heard much about, uterine cancer, which is also known as endometrial cancer, and ovarian cancer. Those are the primary ones. And so each of those cancers has different risk factors, different periods of time that you should be screening. Breast cancer, we screen mainly by mammogram, starting usually around the age of 40 and going pretty much to the end of your lifespan. We also do breast examinations, clinical breast examination, which is where your doctor does an examination of your breast. And then self-breast examinations have kind of changed over time. Historically, we used to teach women how to do self-breast exams, feel for cancers. And recently, it's been basically acknowledged that we don't have a really good ability to teach women to detect what's cancer or not. So we've kind of switched from self-breast examination to what we call self-breast awareness. And that just means being comfortable with what your breasts normally feel like, and examining them, not in a very methodical way, but just knowing what's normal for you. And so that way, if something new comes out or you feel something that's different, you can bring it to your doctor's attention and we can do an evaluation. So that's the main thing for breasts. Cervical cancer is how we look for cervical cancer using pap smears. And the guidelines for pap smears is to start at age 21. In low-risk women who don't have recurrent abnormal paps, we actually are doing them around every 3 years. Different guidelines vary, but actually people think that they go to the gynecologist just to get your pap smear. And we're not doing pap smears in all women every year. We do it about every 3 years and up until about age 65. If they're low risk. Obviously, if they're of high risk, we can continue or we could do more frequent, but that's really the age group that we're looking at. Uterine or endometrial cancer is primarily a cancer of late adulthood, early menopause. The hallmark for endometrial cancer is bleeding in the menopause. So once a woman goes through menopause, which means they haven't had a period for an entire year, they're considered menopausal. If you see bleeding in the menopause, that always requires an evaluation. So any woman who has bleeding after they've stopped having their periods should see their doctor and get checked out, and ultrasounds, examination, biopsy, things like that. Ovarian cancer is the real tough one. That's a real killer for women. It's not as prevalent. There's not as many women who get it, but once they do get ovarian cancer, unfortunately, they're often detected late in the game, often at stage 3, and the options for treating or curing are less effective. And so women really have to be on the lookout for really vague symptoms like abdominal bloating, urinary frequency, unintentional weight gain or weight loss, Those are the main symptoms. And so the way we can evaluate that is very limited. You see your doctor every year. We examine you. We feel for masses in the ovaries. Other screening methods haven't been found to be very effective, like ultrasounds in certain labs. We often do them, but they're not very good at detecting cancers. And then we talked about vaginal and vulvar cancers. That's mainly by inspection, looking at your annual exam for moles or lesions or masses that aren't supposed to be there, bleeding that's out of character. So that's mainly what we're doing for cancer prevention and detection.
So a couple of things you said, and I wanted to focus on the cervix for our viewers is the last part of the uterus. So the first part of the uterus is that portion of the uterus that comes into the vaginal canal, right? And when people have a hysterectomy, should they still go back and get a pap smear?
It's a good question. So there are different kinds of hysterectomies. There's a total hysterectomy, and that means removing the uterus and the cervix. And then there's what's called a subtotal or supracervical hysterectomy, where sometimes doctors remove the uterus, but not the cervix. If you don't have a cervix, you don't really need a pap smear. Pap smears are for detecting cervical cancer, and there's really no indication to do paps if you don't have a cervix. If you still have your cervix, you still need paps, even if you have a hysterectomy.
All right. So what I've heard is, go to your gynecologist. You should go to the gynecologist starting at what age?
Well, it depends. If your pediatrician is not seeing you after 18, then you can start around that time. You can even go earlier if you're having menstrual related issues or birth control issues that your pediatrician can't take care of, but at a minimum by 21.
By 21. And how about how as it relates to sexual activity? You hear that if you're not sexually active, you shouldn't go to the gynecologist. Is that true or not true?
I think that's really a myth. I think that there are lots of things that we do that are unrelated to sexual activity. Like I said, we're a primary care physician for women. After you stop seeing your pediatrician, many women don't get a PCP. They consider their OBGYN their primary care. So there's so many things we're doing that are not related to sexual activity, not even related to cancer, all sorts of health related issues that we're looking at.
All right. And then you talked about postmenopausal. So when you're done with your menses and you're whatever, age 50, and you've stopped bleeding and having your menstrual cycle, if you bleed, that's abnormal. And of course, seek gynecology. What happens if you are bleeding and you're a young individual and it's not menstrual cycle and you're bleeding off and on and so forth? You should see your gynecologist as well for that?
Absolutely.
What things are we worried about at that point?
So one of the things, if you're bleeding after sex, for instance, that's called postcoital bleeding, that can be a hallmark for cervical cancer or precancer. It may not be. There are a lot of things that could be that are not related to cancer, but there's so many things that can cause irregular bleeding. Stress can cause irregular bleeding. Pregnancy obviously can cause, a change in your menstrual cycle. Infection. What we call cervicitis can cause bleeding. There are all sorts of little tumors that are benign, like polyps or fibroids, that can cause abnormal bleeding. Ovarian cysts can result in bleeding irregularity. So if you have a change of your menstrual cycle that's not normal for you, I think you need to reach out to your OBGYN, let them evaluate you, initiate a workup so we can see, is this something that we need to worry about or not?
All right. So what I'm hearing is that every woman, after you're done with your pediatrician, should get an OBGYN, should see your gynecologist every year. You're not going to get a pap smear every year. I've learned that. I didn't realize that. I thought it was pap smears every year. So now we're doing them every 3 years. And then, whether or not you're sexually active, even if you're a young woman, you should see your gynecologist. So one of the other things I wanted to kind of portray in the life, and, everybody wants to know, what does a doctor do all day? And there's a lot of this reality TV, but OBGYN is kind of a little different because, you have doctors that, you have to run, you have to take care of a delivery and so forth. So what is a typical day outside of your presidency of your medical staff? Because we know that's it's a lot more, but in OBGYN, what is a typical day like?
Sure. And I think that's one of the really exciting things about OBGYN is that we don't have a very typical everyday that's the same, right? We're not always in the office or always in the operating room. So there are three main places that we're at: in our office, on the labor delivery floor, delivering babies, and in the operating room, because OBGYN is a surgical subspecialty. We do hysterectomies and laparoscopies and all sorts of procedures. So a typical day for me really varies. Some days I'm in the office. Most days I'm in the office. Some days I go to the operating room to do scheduled surgery, whether it's in the main operating room or ambulatory surgery for outpatient, more minor surgeries. And then sometimes I'm in the labor floor. Sometimes I'm scheduled there for, let's say, a C-section. And then if I'm on call for my group, we share group calls when a patient goes in labor. So, it's not just days, it's nights and weekends. Going in the middle of the night for a delivery is kind of a standard operating procedure for us.
Wow. Yeah, no, I know that's different for me. It's rare that I'm going to have to get up in the middle of the night to do something. So now, in regard to surgeries, you talked about surgeries. What type of surgeries are gynecologists doing, or the women need from a gynecologist?
Sure. So the most major surgeries we do are like hysterectomy, taking out your uterus. myomectomy, removing fibroids, which are usually benign tumors that cause pain or bleeding or pressure. We do laparoscopy, sometimes with robots, robot-assisted laparoscopy to deal with endometriosis, ovarian cysts, fibroids, and things like that. There's more minor surgeries. Probably the bread and butter for an OBGYN is a procedure called a DNC. That stands for dilation and curettage. That's basically putting a camera inside the uterus and looking for abnormal pathology inside, like polyps or fibroids, and basically cleaning things out. Sometimes we surgically excise fibroids or polyps. We also tie tubes. We do procedures for precancer of the cervix, a procedure called a LEEP, which is loop electrosurgical excision procedure. We remove the precancerous cells from the cervix. Those are the mains. We do, all sorts of vaginal surgery. And then there are also subspecialties of OBGYN look at fertility, urinary incontinence or prolapse. There's a subspecialty for gynecologic cancers. And then high-risk OB is another subspecialty.
Wow. Yeah, no, I was going to ask you about that. So there are, you do all the OB and GYN, but then there are subspecialties of people that operate on the cancer patients and people that do all the incontinence and women that have that prolapse and so forth.
Yeah. Exactly.
Yeah. And so let's change gears a little bit and let's talk about pregnancy. All right. And what type of things, advice would you give a young woman who's considering pregnancy or is pregnant? Are there things that you need to do beforehand, before you get pregnant? And, and then we'll go through the steps during pregnancy. And then later on, I want to talk a little bit about, natural birth versus C-section and so forth. So,
Sure.
So before you even get pregnant, what should you be considering as a young woman?
Well, I think, it goes without saying that you want to optimize your health in anticipation of pregnancy, right? Your baby is living inside of you. You're providing a nurturing environment for the baby. You're providing the nutrition. So, staying away from excessive use of alcohol, cigarette smoking certainly would be something to try and quit doing before pregnancy. Not using illicit drugs. Those are all important things. And then optimizing your nutritional and metabolic health. So trying to achieve, as close to an ideal weight as possible, because being overweight in pregnancy does have its risks of things like diabetes and hypertensive disorders of pregnancy. Having a healthy diet is important. You're providing those building blocks for that baby. Having some kind of regular exercise so you're in good cardiovascular health. Some of the most scariest things that can happen are hypertensive emergencies where women have high blood pressure during pregnancy, or bleeding emergencies in pregnancy, and it can be quite dangerous. So you want to optimize your health beforehand. Take a prenatal vitamin, which is basically just a multivitamin, to kind of make sure you have the right, vitamins and nutrients in anticipation of being pregnant.
All right. So then, taking care of your health beforehand, no smoking, limit alcohol, and being fit and, doing exercise. Now you get pregnant, you should go see your gynecologist. How soon after you do that home pregnancy test?
Yeah, I think that really varies from doctor to doctor. In my practice, we really are very proactive. As soon as you tell us that you're pregnant, we want to see you within a week or two, just to, optimize your health, make sure you're not on any medications that are contraindicated in pregnancy, establish that the pregnancy is a healthy one. If God forbid you have a miscarriage or an ectopic pregnancy, which is a pregnancy that grows outside of the uterus in the tube or elsewhere, and that could be quite dangerous. We want to be aware of all of that. So, once you've got a positive pregnancy test, call your OBGYN, make an appointment. I would say within a few weeks is pretty reasonable.
Okay. And then what about vaccines during pregnancy? That's a topic that I've never really heard about. Of course, not my area of expertise, but right. Tell us about vaccines in pregnancy.
Yeah. So vaccines, obviously, in some areas, a very controversial topic. Generally speaking, most vaccines are very safe and actually advised in pregnancy. So obviously right now we're dealing with a COVID pandemic. COVID vaccine has been shown to be extraordinarily effective and safe in pregnancy. In fact, pregnant women who get COVID are at high risk of adverse outcomes. They can have earlier deliveries, they can have miscarriage, they can have blood clot issues. So we do recommend COVID vaccine. All women should get vaccinated for the flu in pregnancy if it's flu season, because women who are pregnant who get the flu can get really, really very ill. I've seen patients in the ICU. When we had the swine flu and the bird flu, they can get quite ill. There's a vaccine that we recommend for all women in the third trimester called a Tdap. That's tetanus, diphtheria, and pertussis, mainly because of the pertussis or whooping cough, which is a pulmonary infection. And it basically provides protection for the baby while the baby's in utero and in the immediate postpartum period for several
Wow.
months, because you have antibodies that cross through the placenta, and then if the mother is breastfeeding, through the breast milk, because the baby can't get vaccinated against pertussis until several months after birth. So that's an important vaccine as well. So those are the main ones we're looking at: Tdap, flu, COVID. There are some vaccinations that are considered live vaccines, like hepatitis, that we don't give in pregnancy. But those are the primary ones.
Wow. So completely what I didn't think of, that so much vaccination during pregnancy. That's incredible. And it's, as we've seen and through the COVID pandemic, very beneficial for the patient. All right. So the woman has come to see you. They are going through their pregnancy. Now they're getting to what we call term, and they're about to deliver, and it's time. They're 9 months for our lay public. We know it's 40 weeks or 38 weeks. So let's talk about when you should be delivered and how you should be delivered. And let's talk about the end of pregnancy. What are some guidelines you'd give the women?
Sure. So your due date is when you turn 40 weeks. Historically, 37 weeks on was considered full term. So if you delivered before 37 weeks, you'd be considered preterm. Over the last 10 or 15 years, we've recognized that there's actually a difference in that term period. So whereas 37 weeks historically was considered fine, we now know that the brain and the lungs take the latest to develop, and it is ideal in a healthy pregnancy to deliver after 39 weeks, because women born before 39 weeks or babies born before 39 weeks have a little bit of a higher incidence of breathing issues and brain developmental issues. So we try and delay till 39 weeks. Of course, if you go into labor or you break your water, that's a different story. Or if you have medical conditions like blood pressure issues or diabetes, that might change our advice, twins and things like that. But generally speaking, we try not to electively induce or deliver people before 39 weeks unless they're in labor on their own.
Okay. So you're at 39 weeks. What do you guys do? You just wait for them to go into labor?
For the most part, it is safest to let your body go into labor on your own, right?
Okay.
So inducing labor, there are indications. There's medical indications to induce labor. There are elective indications, meaning just because we want to get the baby out. But for most people, letting your baby go into labor spontaneously, letting your body go into labor spontaneously, is the best way of trying to get to a natural or vaginal delivery. Inducing or putting women into labor before their body naturally does so can, in many circumstances, increase the risk of C-section. Not that there's anything wrong with C-section per se, but for many safe deliveries, a vaginal delivery is ideal. It's a quicker recovery and less pain and less risk in some regards. And so when looking at the general population, letting someone go into labor is usually the best bet. Now, we don't let people go into, wait forever.
Yeah, I was just going to ask, how far? How far?
In our community, about a week past your due date. At 41 weeks, if you haven't delivered, at that point, we'll usually have a conversation, recommend induction of labor. You start to get to an area where there's pros and cons. Other communities will let people go, further, but in our community, usually it's about 41 weeks.
Okay. So you haven't delivered, or you're getting to term, and you need to deliver. Are we doing vaginal delivery? Are we doing C-section? What's better? And I know in South Florida, because of the Hispanic community, and I know enough of this, that there's a lot of C-sections in South Florida. So talk to us about that and what's better for the patient and why so much C-sections.
Yeah. So, we're not trying to eliminate C-sections altogether. There's definitely a role for C-sections in lots of conditions. For instance, if your baby's breech, meaning the baby's not head down, but butt or feet down, it's been proven that you're much better off with a C-section.
Okay.
Some people try and turn the baby. That can sometimes be effective. But if the baby's stuck in the breech position, there's no question a C-section is ideal. That being said, there is a high rate of C-sections in South Florida for a lot of reasons. Part of it is the Hispanic influence, because we know in South America there's a lot of preference towards C-sections. But there are a lot of different things that go into play there. And as I was saying earlier, vaginal deliveries are, in many circumstances, the best option. It's what I consider to be the default option. Now, if your baby is extraordinarily large, or your pelvis is very small, or you have twins, or like we said, breech, or for any of a number of other reasons, we might consider a C-section. You also may start to go into labor and your labor may falter, right? You may stop dilating, or you may push and you may not be able to deliver the baby. So there are a lot of indications why we may change our tactics towards a C-section. But I think that in general, are kind of, we should lean towards a preference of vaginal delivery for most patients, and individualized care, of course.
And I think I know the answer to this, but if you've had a C-section in the past, you don't have to have another C-section again. Is that right? You can have a vaginal delivery after a C-section?
There is that option. That's called a VBAC, which is short for vaginal birth after cesarean section. And some patients are good candidates. It really depends on why you had your C-section the first time, characteristics with this one, with this pregnancy, patient preference, physician preference. That really just varies from place to place.
Wow. So we've talked a lot about OBGYN. You've learned about, gynecology, seeing your gynecologist every year. You don't need a pap smear every year, every few years. Your breast evaluation, your gynecological organs evaluation. And we've talked a little bit about pregnancy, being in good health, no smoking, and so forth, and seeing your OBGYN, your OB for your pregnancy. So now let's shift gears and let's talk about the other hat you wear, the president of the medical staff. And first, tell us, why would you want to do that? I mean, I've been at Baptist as long as you, and I've been on that executive committee for a long time, and I never wanted to do that. Why would you want to do that?
I think that it's a great question. I think I'm passionate about leadership. I think that, I want to make a difference in our community. Baptist Hospital has been a part of my life since I was a child. I volunteered there in junior high, and I've been on staff for almost 20 years. And I just think that we can play a real role in making a difference in our patients' lives and just looking at the community as a whole. So not only as a women's care physician, but something I've been really focused on is mental health. We pioneered a program about 15 years ago at Baptist where every single patient who delivers their babies at Baptist Hospital gets screened several times for postpartum depression. We've saved a lot of lives that way.
Wow.
And actually it's been determined that that's really the best practice. And Baptist Hospital has been a model for other hospitals around the country. We now have an issue, with COVID, where we're seeing a lot of burnout with nurses and doctors, mental health issues. Unfortunately, we see suicide in physicians, which is just a tragedy. And so I really think that I can help by establishing, a task force that can look at improving healthcare and mental health in specifically in our healthcare providers, nurses, doctors, allied health professionals, bringing the resources to them in order to make sure that, if we have healthy healthcare providers, they can therefore have healthy patients.
Wow. So one of your goals is really mental health. And what do you think of some of the other areas that you really can make an impact as our president?
Well, I think Baptist Hospital is kind of embracing a new focus going into the future. Baptist has been around forever and has been a great community hospital, but something that's happening, as you well know, is that we're starting to get involved with what's called graduate medical education. Mm-hmm. So we're bringing medical students, residents onto our campus and training them. I know you'll be involved in training the future surgeons of America, which is amazing. And so we have this new focus where we're going to have all sorts of people being trained as the future doctors at Baptist. So I think that's somewhere where we need to really embrace and make sure that we optimize and do the best job that we can. I've been very active, involved with leadership development, developing a pipeline of future leaders, right, making sure that the people who are going to be leading our medical staff and our administration are well-trained, diverse, represent the community that we are involved in. I think also with what's going on with this recent pandemic is we have to have preparedness for emergencies. So I don't know what the next pandemic is going to be. We had Zika a few years ago. We almost had Ebola on our doorstep. Yeah. We've got all sorts of issues now. We've got digital security to worry about, ransomware. That's something that's gone on in healthcare facilities around the country where hackers get into your system and lock your medical records. So we need to be prepared for that. And I think also another focus is embracing the digital era, smart rooms and apps and bringing healthcare to the consumers where they're at. Because, the people, the younger people now, they want to be able to get on their smartphone and book an appointment or do a telemedicine appointment. And so I think we need to embrace that. So we're providing healthcare at a way that the consumers are really looking for.
Yeah. And I see patients all the time who they look at their results. By the time you get to the room and see them, they already know what their CAT scans or what their labs are and so forth. So they're very, very involved. Yeah. So what do you think is going to be your biggest challenge now in the next couple of years?
Oh, well, that's a good question. I don't really know. I think what I found in the short period of time that I've been president is that every few weeks there's some new challenge. whether it's COVID or it's a crisis with the medical staff, or a bad outcome, unfortunately, sometimes can occur. And just being nimble, being agile, responding in a timely fashion, I think is the challenge. Is just mobilizing the resources that we need to optimize the way we deliver healthcare.
Wow. So what would you tell a youngster out there, whether it be a high school student or a college student, which I have a couple of them that are on my doorstep that are going to spend some time with me this summer, and they want to be a doctor? What's your words of wisdom for the future people that are going to take care of us and our children?
Yeah, I mean, look, I think it's important to realize that medicine is not just a career; it's a calling. I spend a whole lot of time. It's not a 9-to-5 job. I deliver babies in the middle of the night, take phone calls, throughout the weekend. It's something that you need to be aware of, but there's no better job than being a doctor, taking care of people, making a living, doing something that's beneficial for others. You just can't beat it. So you have to have dedication. You have to be smart. You have to have a good work ethic. But I think it's just an amazing job. I'm sure you'd agree.
Yeah, no, I think I've always said, and I was with a patient this morning who was actually another physician, and I said, listen, the day you find the job that you love to do, you'll never work a day in your life. And I think that's the passion. I mean, I think for a youngster, I would tell them, make sure you're in medicine because that's what you want to do, not what somebody else wants to do.
Absolutely.
Somebody else wants you to do, because then you'll be spending a lifelong answering phone calls and coming in to do emergencies for somebody else that's something you didn't love. But again, I thank Jason for being here with us. We've learned a lot about women's health today. We've learned about gynecology as well as obstetrics and pregnancy. Our women out there, go see your gynecologist, get your checkups, be healthy during pregnancy. And of course, understand that the medical staff members that we have at Baptist, what do we have, like how many, 2,000? How many doctors we have at Baptist? Like a couple thousand doctors at Baptist. You need representation. And Dr. James is the one that represents us to the administration, and that's what the president of the medical staff does, as opposed to a CEO as well. So thank you again for being here. Thank you for what you do for our community for the last 20 years. Once again, Dr. Anthony Gonzalez from Miami Community Health, signing off.